Hello, I am Dr. Ahilasamy from India. I'm going to show you a case of Haemorrhagic Necrotic right Antrochoanal Polyp FESS under local anesthesia. I am doing with the IV sedation. You can see the coronal CT scan images now showing the opacity in right maxillary sinus and right nasal cavity, and there is heterodensity in the right maxillary sinus. That may be due to the hemorrhage. This patient is a 25-year-old female delivered just 5 days ago, normal delivery, and she had bleeding for the past 1 month. This MRI scan images. The quality of the scan were quite inferior, and the radiologist gave a diagnosis of fungus in the maxillary sinus. That is, they misdiagnosed the hemorrhage, old hemorrhage in the maxillary sinus as fungal. This DNA patient taken under local anesthesia, very comfortable. It's a reddish, angry looking polyp, not the classical antrochoanal polyp. She was bleeding for the past 2 months. Even though the images were taken 5 days after delivery, she came for surgery only after a month, stabilizing the young one, that the baby, with artificial feeds. The first step is to decongest the mucosa and the polyp with a good packing with a roller gauze soaked in 4% lignacin and adrenaline. You have to pack repeatedly to get a good analgesic effect of the mucosa and the decongestion. With a small cartilage elevator, insinuate the roller gauze wick into the middle meatus. I don't prefer the Mucosal or Ivolon, which is quite bulky. Of course, you can use patties, neuropatties. This is a way. You have to do it repeatedly without injuring the middle turbinate, septum, or the inferior turbinate. The key to this thing is there is no space to give a spinopalatin block or any intranasal blocks. So I am going for the greater palatin block. This is the only block I am laying to do the surgery. If this block doesn't work, then this surgery cannot be done. I am palpating the foramen of the greater palatin canal. Then I am bend the needle for about 1.5 to 2 centimeters. A 23 coil spinal needle. So I am trying, but the needle is not going, but that means I am not in the foramen. Even though an seasoned, experienced person may, like me, can find difficulty in finding the foramen in young people. In adult people, this aged people, the foramen will be quite little bigger. So that's not the foramen. Needle, the bent part has to go in. Now I am going to the second spot. No, again I am missing it. That's the third spot. Again I am missing it. Finally I could get into the pot and giving the block. You should be confident of the foramen area also to do this kind of cases where the polyp is fully occupying the nasal cavity. Around 1.5 cc of 0.5% ropivacaine with adrenaline I am injecting. The patient is very comfortable and they have to open the mouth and show no need to put the tongue depressor. And injecting slowly after aspiration. Air should not come into the syringe or blood should not come into the syringe. You can see 2 centimeters of the thing has been gone in there. Again I packed the thing for a few seconds, have a decongestion effect. Next step is to truncate the antral and choanal part of the polyp from the nasal and choanal part of the polyp from the antral part. You can just cut it or you can use the debrider. Already it's started to bleed. It's a very vascular. But here I am taking it out because I need lot of biopsy because it is not an usual polyp. It can be any other pathology also. Of course, it looks like a hemorrhagic necrotic polyp according to me. This choanal part looks like a polyp. Antrochoanal polyp, but the nasal and the antral part were very hemorrhagic and the antral part in fact is necrotic. So lot of specimen I am taking for biopsy. So rest of the polyps I am shaving with the Microdebrider. To make the lumen patent. Then we have to attack the antral part. You can appreciate the field under local anesthesia even though it's a hemorrhagic polyp, hardly any bleeding. That's the beauty of the local anesthesia. We don't give any hypertensive drugs. Hardly any bleeding in the nasopharynx also. Trickling into the nasopharynx. Of course, small trickles, you have to immediately suck it out or ask the patient to swallow. See the clarity field. Now I am giving the spinal repellent block, which is not needed in this case. Already the greater repellent block has taken well. But if that is not done properly and the patient has pain, this block helps you. So this is just I am giving this case just to demonstrate the youngsters. If that doesn't work or the patient has more pain, that means you give an added block after removing the polyp. Now I am doing the mini FESS on the right side, that is taking out only the lower 1/3 of the uncinate with the backbiting forceps, that is Nagashima's backbiting forceps. See the antrum is filled with a hemorrhagic necrotic polyp. I will take more specimen. See, that's a collected hematoma. Old collected blackish blood clot. This was shown in the CT or MRI as a the radius means interpreted as a fungus. So this necrotic polyp is taken for biopsy. Again some more hemorrhage. This is hemorrhagic antral part. You can use a shaver and take it out all, but here I am carefully in taking out all the material for biopsy. Just delivering with a curved sucker and taking out with the Blacksley forceps. Now I am using the shaver to little more widen the MMA, that's a mini FESS, and taking out the some of the more antral hemorrhagic polyp. All this will go for histopathological examination. Now the antrum looks clear with a 0-degree telescope. Now I am shifting to the 70-degree telescope. Still I am not happy. There is some attachment anteriorly. So I am using a RAD 60 blade and 120 blades to take out the anterior attachments. I had the 90-degree telescope also, but with 70 itself I had a fair view. If I can't, I will use the 90-degree telescope. Still I am not happy, there is some attachment. So I am using the RAD 120 blade to take out the polyp. Anterior attachment, which is very important. If you leave behind the attachment, the antrochoanal polyp will recur. Now I am using the couverture to take out the final attachment. That's the final attachment on the anterior and the anterolateral wall, mostly on the anterior wall. See, just pulling it out along with the mucosa. Of course, the attachment area you can take out along with the mucosa. Now it looks clean. There's a small bony spicule on the floor. I'm taking out with the backbiter. Don't leave raw bones. Hardly any bleeding. Now with the 0-degree telescope. And we don't pack the nasal cavity, and we discharge the patient the same day. No pack for any nasal and sinus surgery cases. Thank you for watching.